Well, we are benefiting from an increasing number of drugs that are of interest, that are targeted agents, where we have a mechanistic understanding of certain aspects of leukemogenesis and the ability to interfere with very specific leukemogenic signaling pathways, for example, or leukemia-associated antigens in case of immunotherapy. Or maybe one of the fundamental problems is that we are increasingly breaking down the diseases into smaller and smaller subsets. So the more clearly defined genetic subsets we have with potentially specific targeted therapies, the fewer patients we will have in each of these subsets, which makes the classical approach of a big randomized comparative trial very problematic, because you just don't have the patient numbers that meet the statistical criteria for these classical designs. I would see this as the main challenge, and the consequences will be that one has to embark on ideally international collaboration to get the patient numbers, and probably also to look at some innovative methodological designs, study designs, and, to be able to address this. So it's peculiar that actually in the same vein as we are having more opportunities, we are struggling more to actually test them and get them into the clinic. The range of drugs is quite impressive. There are probably of considerable interest at the moment are the apoptosis interfering drugs, so the pro-apoptotic agents like venetoclax, BCL2 inhibitors, BCL-xl inhibitors, maybe even combinations, and certainly in combination with other agents like hypomethylators or chemotherapy or targeted agents, which again shows you that by trying to identify the best combination therapy, and I think this is not going to change. We will not rely on any single treatment modality or drug to suddenly be curative. It will be the combination used in a rational manner, sometimes sequencing, sometimes together. But this, of course, adds the complexity to the study design over just testing a single agent. Some might consider it a luxury problem, but we will have to address this. And I'm really very hopeful that pan-European approaches where study groups collaborate, which is increasingly the case, will help us to enroll the patient numbers needed to find the correct answers and benefit the patients.